Hi, I'm Dr. Charlie. I'm a lead GP and a senior university clinical educator. In this video, we will discuss different types of diabetes based on a newly revised classification from World Health Organization 2019. We will start with type 1, then type 2. We will then discuss rarer form of diabetes, including MODY, ketosis-prone diabetes, and slowly evolving immune-mediated diabetes, previously known as LADA. We will discuss the use of C-peptides and autoantibodies. We will then guide you into how we should diagnose diabetes correctly. Coming right up. Diabetes is a very common condition in the UK where the body has difficulty controlling blood sugar. Beta cell of the pancreas is the key. It produces insulin, unlocking the cell to allow the glucose in. Diabetes happens when the pancreas fails to make enough insulin or not making it at all, or it fails to work properly because the tissue is more insulin resistant, leading to high blood sugar. In 2019, World Health Organization produces a revised classification removing subtypes for type 1 and type 2 and introduces hybrid and unclassified diabetes. In type 1 diabetes, there is a beta cell destruction, which is mostly autoimmune mediated, leading to absolute insulin deficiency. The presentation can be rapid in childhood and early adulthood, as seen in diabetes ketoacidosis or DKA. There is an element of genetic predisposition and a family history of autoimmune condition such as thyroid disease, celiac disease, and rheumatoid arthritis, for example. There are autoantibodies that have been identified against the beta cell components such as GAD, IAA, IA2, ZNT8, and they are present around 85 to 90% of type 1 diabetes. In clinical practice, however, this has limited value, although it may have a role in type 1 diabetes when there is uncertainty between type 1 and type 2, but this should not delay the start of insulin. C-peptide is a way of measuring endogenous insulin and is usually done fasting. It can give useful information in the early stage of diabetes to distinguish between type 1 and 2, although this is not done routinely in clinical setting. In classic presentation of type 1 diabetes, C-peptide will be very low or undetectable. Type 2 diabetes is the most common and is accounting for around 90% of cases. It is characterized by insulin resistance, dysfunctions of the insulin production by the pancreas, and liver excess production of glucose. Obesity is common, and about 6 in 10 patients will not have symptoms at diagnosis. In some ethnic populations, such as Asian and Indian, beta cell dysfunction can be seen in thinner people. Now let's talk about other types of diabetes. We think around 3% of patients being diagnosed with diabetes before the age of 30 are misdiagnosed in terms of its types. First, we have maturity onset diabetes of the young or MODY. It has features of severe insulin resistance without obesity. There is a monogenic defect of the beta cell function. Currently, there are around 33 genes identified. The most common type of genetic defect in MODY is HNF1 alpha, accounting for around 50% of cases. MODY is often run in the under 25 age group and it also runs in family. So if a parent has MODY, there is a 50% chance that a child will also get MODY. It leads to diabetes by lowering the amount of insulin being made. It is not a type 1 diabetes as there is no auto-destruction of the beta cell. The pancreas will continue to make insulin but to a lower amount. MODY is usually treated with glycoside to stimulate more insulin secretion by the pancreas, although later on supplementary insulin is required, especially with high HBA1C and BMI. Exeter is the Centre of Excellence in the UK, and I will leave you a link in the description below for more information and training. Let's talk about hybrid diabetes. First, we have slowly evolving immune-mediated diabetes. It is used to be called LADA or latent autoimmune-mediated diabetes. It is similar to slowly evolving type 1 diabetes. It is often seen in adults over the age of 35 who initially will not be requiring insulin in the first 6 to 12 months after diagnosis. There is a single autoantibody, usually GAD, and the patient will retain greater function of the beta cell. Next, we have ketosis-prone type 2 diabetes, which is another hybrid. The patient will present with ketosis or diabetes ketoacidosis DKA, but later on will not require insulin. It is less common in the Europeans. While initially presenting with DKA, it will subsequently resemble typical type 2 diabetes. There is no genetic marker and no autoantibody, so this is not a type 1. There is this transient secretory defect of beta cell with remarkable recovery of the insulin secretion capacity. We are not going to cover other unusual forms of diabetes such as drug-induced diabetes or other monogenic types today. Let's talk about how we can diagnose diabetes correctly. Clinical features of diabetes may include thirst, urine frequency, tiredness, weight loss, recurrent infection. You can also get skin pigmentation in the skin fold called acanthosis nigricans, which indicate insulin resistance. HBA1C or glycerated hemoglobin is a blood test that measures the amount of glucose attached to the hemoglobin in the blood. It identifies the average blood glucose over a prolonged period of time. Because generally red cells survive for 8 to 12 weeks, it provides a long-term gauge of diabetic control. When using HbA1c to diagnose diabetes, no fasting is required, although it has disadvantages. As its concentration is determined by the glycemia during the life cycle of the red cells, patients with abnormal red cells such as anemia or hemoglobinopathy such as sickle cell anemia, HbA1c will not be ideal. You should not use HbA1c to diagnose diabetes in pregnancy, diabetes in children, or type 1 diabetes. We should also not use HbA1c in patients with end-stage renal failure or HIV. Fasting blood glucose in these circumstances will be a better choice. Fasting blood glucose means refraining from eating or drinking apart from clear fluid for at least 8 hours. Fasting blood glucose of more than 7, random blood glucose of more than 11.1, or HbA1c of more than 48 are diagnostic of diabetes. If a patient is symptomatic, a single abnormal HbA1c or fasting blood glucose can be diagnostic, although it is sensible to repeat the blood test. In an asymptomatic patient, do not diagnose diabetes based on a single abnormal result, but it should be repeated as soon as possible. If the repeat sample is normal, the patient should still be monitored. In the following videos, we will discuss diabetes emergency, including DKA, diabetes in pregnancy, and prediabetes. Now, if you really enjoyed the content of this video, why don't you check out the other video I've made for you on diabetes medication update based on NICE Guideline 2022. And don't forget to like, comment and subscribe to my GP Team Academy channel for a weekly educational video update. And until next time.